From clinical trials in South Africa to the international company that makes CAB LA. Dr. Kimberly Smith led the studies at ViiV Healthcare that tested the jab. Dr. Smith, thanks very much for joining us today. Which countries already use the jab?
Well, so CAB LA for PrEP is currently approved in the United States and in Australia, and it's approved recently in Zimbabwe. It is currently available in the United States. It's not quite yet available in Australia and Zimbabwe.
In Africa, to a large extent, how accessible this jab would be would determine on the price that you would sell it at. And earlier this year, ViiV did say that it will sell the branded product while we wait for generic products at a cheaper price for poorer countries. Have you decided on a price?
What we've said, repeatedly, and that nothing has changed about that, is that we will make it available until there's a generic company that's available to produce it. We will make it available at a not-for-profit price. And so we're doing everything we can, including a number of partnerships, to try to make that price as low as it possibly can be. And so I can't give you a number, but I can tell you that it is a not-for-profit price.
Is there a timeline for how long the negotiations for the price will still take?
It's not so much negotiations for the price. As I mentioned, the goal is to get the price as low as possible. And so some of that depends on volume guarantees and a number of aspects. But I think it's important to remember that, CAB for PrEP is a sterile injectable product. It is a very, very complex manufacturing process. And I think the places where it's been compared to sort of the manufactured cost of a simple white pill are just not realistic.
For you to offer an affordable price, you obviously need to have some sort of guarantee of how many orders you'll get in order to produce it at scale and then to make it cheaper. Do you have an idea of what is the kind of minimum order that you would need to make this viable for you?
Yeah, I can't really give that number yet either, but what I can say is that the partnerships that we have with groups like Bill and Melinda Gates Foundation and SIF and Unitate, those partnerships are critically important for helping us to understand what the demand will be and what the volume requirements will be in the early years as well as it ramps up over time. And we clearly understand that the volumes will increase over time and that will allow, for improvements in the price.
If we look at manufacturing capacity, say if you agree on a price tomorrow and you have to start manufacturing at a very large scale, is ViiV able to do that? And how long will that take? And can you do that consistently because you've been manufacturing at a much lower scale up until now?
We have been working with our manufacturing partners in GSK to really do everything possible to maximize our capabilities. And so, we hope that those match the demand, and we'll, again, need to understand more about what the demand will be in the short term.
Do you have an idea of what the maximum capacity it is that you can manufacture, say, annually?
That is changing as we optimize our manufacturing capabilities. I don't want to commit to what we can deliver. It'd be nice to really get some clear understanding about what the demand will be year by year, and that's what we're working on with those partners.
Has ViiV had discussions with the South African government with regards to price?
So we have submitted to the South African government the product, obviously, for regulatory review, and there are not negotiations with the South African government, as far as I understand at this point.
So one of the challenges with creating a market for HIV prevention is to get healthy people for this injection to clinics, and that can be quite a challenge. So what does clinical trials tell us about adherence? Do people, when they start to use this, do they regularly return every 2 months, or are there problems around it?
So what the clinical trials told us is that people were tremendously adherent, and that led to the tremendous outcome where we were 3 times more in men who have sex with men and transgender women, and 9 times more effective in cisgender women. And so both superior statistically. And so that is an indication that people definitely did show up, on time. I mean, obviously there's some flexibility. We have a little bit of a window around the dosing, that allows for flexibility. You have a week before or after that exact date where you're scheduled.
With a rollout in the US that is now obviously been in real life and not in clinical trials, have you seen any signs that indicate that it might be different in real life, the adherence, or a little bit less good in the real life, or does it look as if it's all working?
We've only been on the market for a year, so we haven't seen any difference from what we saw in the clinical trials thus far, but it's still fairly early. But I think long and short of it is that we saw in the clinical trials very high rates of adherence, and part of that is that people did really tell us that they enjoyed the comfort that they had from feeling like they were protected, and so coming in every 2 months was a relatively small price to pay for that kind of satisfaction and the freedom that they felt from not having to worry about taking a pill every day.
One way to get women to clinics, especially young women, is to combine it with contraception when they visit the clinic for contraception. But in Africa, the form of contraception that's the most common is an injection that you get every 3 months. So are you looking into whether CAB LA could perhaps be given 3 months as well? Are there studies like that going on? Because it might make it easier on this continent to get women there regularly for the injection.
So that's a great question. So yes, we are looking into that. And what I can tell you is that, remember that part of the 084 study that was the cisgender women study was, taking place during some of the worst times of COVID in South Africa. And basically all the women were enrolled in South Africa or Southern Africa. And so we allowed for some flexibility so that women could, if they needed to, come in every 3 months during that period of time when it was sort of difficult. A lot of clinics were closed and that sort of thing. And so that happened in roughly 200 women, and we didn't see any negative consequences of that. We are doing more work to try to understand if CAB can be dosed every 3 months. There'll be some data shared on that at the conference on retroviruses and opportunistic infections, or the CROI conference, early next year. But certainly that is something that we are exploring.
One of the concerns that's raised in South Africa and other African countries is that cabotegravir falls into the same antiretroviral drug class as the dolutegravir that is used in first-line treatment in most of African countries, and that there could potentially be some resistance that could be built up if there are infections. Is that a big concern on your side?
Well, I can just say that it has occurred, but very rarely. And so, it's something to recognize as a potential risk, but from the clinical trials that occurred, very, very rarely.
When you say it has occurred, you say infections has occurred, right?
Right. Infections have occurred. And in rare cases, there was some evidence of resistance to integrase inhibitor.
Side effects of the jab, how did that play out in clinical trials? What was most common, and what did women say, or men, is hard for them to live with?
So injection site reactions are fairly common in the beginning, and they tend to decrease over time as either people get better at giving the injections or people who are getting the injections get used to it. And so it's mostly pain. People feel, a little bit of soreness at the site where they get the injection. Discontinuation as a result of injection site reactions was extremely rare. Actually, in the 083 study, we saw it in a relatively small percentage, but in the 084 study, which was cisgender women, there were no women who discontinued as a result of injection site reactions. I like to say that women are tougher than men.
Lastly, do you think this injection could be a game changer in the acquisition of new HIV infections? I know that one product alone can't turn everything around, but do you think it can play a bigger role than what we've seen in the past?
I absolutely believe that cabotegravir for PrEP can be a game changer. We've not seen a product have this level of efficacy at all in the past. And so to be able to make this widely available, I do think this has the potential to change the trajectory of the HIV epidemic in the places where it is it is implemented. I had the pleasure of going to South Africa back in August, and I got to speak to some of the young people who participated in the clinical trials. And one of the things that I did was thank them and tell them, one, how incredibly proud I was of them, and that, what they've done really could change HIV for the world. And that's a tremendous contribution that they have made.
Thanks very much for your time. I appreciate it very much. That was Dr. Kimberly Smith, who led ViiV Healthcare's CAP LA studies. She's also the head of research and development at the company.